Pyloric stenosis. Key points. Correction of fluid deficit, electrolyte, and acid-base abnormalities is the priority. Surgical management can be delayed until the above are corrected. Background. Hypertrophic pyloric stenosis, HPS, usually presents between 2 and 6 weeks of chronological age with progressive non-bilious vomiting. Risk factors include, male, firstborn, parental history of HPS, especially if mother affected. Assessment. History, vomiting, recurrent and progressively more forceful. May be projectile. Soon after feeding. Non-bilious, blood-stained in up to 10% of cases. Often hungry afterwards. Weight loss or inadequate weight gain. Examination. Dehydration. Assess degree of blank. Weigh and plot on growth chart with previous weights if available. Visible gastric peristalsis, may be more obvious following a feed. Pyloric mass, located in the right upper quadrant at the lateral edge of the rectus abdominis muscle. Best felt from the left side with the infant settled and supine. May be difficult to palpate. May require repeated examinations or to wait for several minutes with hand on abdomen to feel. Differential diagnosis blank. Surgical causes, e.g. volvulus. Malrotation, congenital adrenal hyperplasia. Management, investigations. Capillary or venous blood gas with electrolytes and glucose. Symptom, hypochloremic hypokaliemic metabolic alkalosis. May be seen the degree of abnormality is proportionate to the duration of symptoms prior to presentation. Abdominal ultrasound can be used to investigate if the diagnosis is not established clinically, 95% sensitive in the diagnosis of HPS. Urine microscopy and culture to rule out UTI. Treatment. Gain for access. Stop oral feeds. Insert a nasogastric tube if profuse vomiting continues despite stopping feeds. Fluid management. Purpose. Resuscitation. Fluid. 0.9% sodium chloride. Notes. Fluid resuscitation as required. Not all infants will require fluid resuscitation. Purpose. Deficit. Fluid. 1000 ml 0.9%. Sodium. Chloride plus 5%. Glucose. Notes. Blank. Include potassium in 4 fluids once urine output is adequate, 12 ml/kg/hr. Purpose. Maintenance. Ongoing. Fluid. 1000 ml 0.9%. Sodium. Chloride plus 5%. Glucose. Notes. Surgical correction of HPS is usually delayed until correction of dehydration, acid/base status and electrolyte disturbances. It is particularly important to fully correct serum bicarbonate before surgery because of the risk of hypoventilation/apnoea post. Operatively in the setting of a metabolic alkalosis. Monitoring and management. Repeat blood gas with electrolytes 6 hourly initially and adjust fluids accordingly. Usually aim to fully correct fluid and electrolyte deficits within 48 hours. Blood bicarbonate levels can be used to monitor response to fluid therapy in HPS, therefore plasmolyte is not used in the management of HPS as it contains bicarbonate precursors that may affect this process. Consider consultation with local pediatric team when pyloric stenosis suspected. All confirmed cases should be managed as an inpatient. Note. Consult with a pediatric surgeon. Consider transfer when confirmed or high suspicion for pyloric stenosis. Note. Transfer to a pediatric center. Early. Once an initial management plan is in place. Blank. Consider discharge when cleared by surgical team, tolerating full oral feeds, pain-free.